Hello? Has it started? Okay. Hey guys, good evening. Welcome back to our channel. Hello everyone. Please let me know whether I'm audible or not. Okay, fine. Please give some thumbs up or something so that I can know that I'm audible and there is no issue with the video as well. Okay. So yesterday we had to talk about the trauma, right? And today we'll be discussing about the burns actually. So again, guys, burns is a very important topic as we know that a lot of patients are coming in the trauma unit. But the main thing over here is that all of the burn patients cannot be treated in the emergency room only. There are some patients who should be transported to the special burn center, and there they will be getting their treatment according to their protocols, right? So, yeah, okay. Fine. So guys, before we discuss about the burns, okay, would like to revise the trauma, right, with the help of some MCQs. Okay, so right, okay. So here is the first question, guys. Please try to answer this. Very basic one. The minimum score in GCS, right? Minimum score in GCS. Anyone? Options are there. 1, 2, 3, 4. Okay. The options are 1, 2, 3, and 4. If these are the options, what should be the answer, guys? Okay. Meanwhile, I'm writing the next one. The next question is, if the patient is having, according to GCS, right, the patient is having the Glasgow Coma scale, uh, I would say the verbal response according to the GCS is 1. Okay, so what should be the answer in this case? Fine, I'm just writing the options. Options are inappropriate words, confusion, no response, or only the sounds, okay, or the mumbling, right? Okay. And so the answer for the first question is this would be the 3. I told you the maximum score in the GCS would be 15 and the minimum score in the GCS would be 3. Okay. And over here, the maximum, here they told you verbal response in the patient is 1 actually. So in this case, in any case, if they're asking if the motor response is 1 or if the verbal response is 1 or if the eyes response is 1, then in that case, your answer would be no response. Okay. So that is the minimum score that you can give over here. Fine. Okay. So now I'm going into the burns. Okay. So we'll try to discuss some main concepts of the burns, right? So let's talk about the burns now. Okay. So in the ones, okay, so in the last one, in the yesterday's session, we had a talk about the trauma, right? And in the today's one, we are gonna discuss about the burns actually. So let's assume that you are a doctor in the casualty or the emergency. So over there, the patient comes to you, right? And let's say now this is the burn patient, right? So how will you handle these kind of patients, right? So we'll be talking about the degrees of the burns, the stages of the burns, okay, and how to manage these kind of patients further. But this is the basic one, that how the patient should be treated if the burn patient comes to your trauma unit, right? So in this case, first of all, we are having a very important criteria, that whether, according to this criteria, whether this patient should be treated in the emergency room only, or we should transport this patient, or we should send this patient to the specialized burn center. So that is the first question over here. So over here, according to the American Burns Association criteria, okay, they have actually made the criteria for the burn center referral. Fine. So which patients are actually suited for the referral of the patient in the burns unit? So these are some criteria over here. Sometimes they ask you the questions that which of the following is not the criteria according to American Burns Association criteria for the referral. So guys, here are some important points over here. For example, burns to the, if the patient is coming to your trauma unit, okay, and the patient is having burns to the face, hands and feet, okay, and the major joint, genitalia, perineum, these are involved, then you should better transport this patient to the specialized burn unit, right? Then if the children are coming with children's in the healthcare facilities, the staff is not trained much to handle that children if the burn patient is coming over there. Okay, so in that case also we need to refer this patient to the specialized burn unit. Now, if the concurrent trauma is there, electrical or chemical burns should be handled by the specialized burn unit. Then the full thickness burns or the third degree burns at any age, okay, the full thickness burns, they are usually the third and fourth degree burns, they should be treated in the specialized burns unit, okay. Then if the greater than total body surface area is more than 10%, right, then also inhalational injuries and then patients who need the specialized emotional or the rehabilitation support, they should be transported to the burn center. Now, if we are talking about the burns over here, first criteria is the American Burn Association criteria. Now, the next thing over here is that if the patient comes to you, so you need to give the basic treatment to this particular patient. Now, as we have discussed yesterday in the trauma section, that first of all, we need to look for the primary survey. I told you according to the ATLS guidelines, we need to do the primary survey and the secondary survey, right? Later on secondary survey. So here also we need to actually go for the, according to the ATLS guidelines, what they say is that, in the burns also we are talking about the A, B, C, D. So in the burns also we are going to talk about the A, B, C, D. So A for again airways, right? B for breathing, okay. C for circulation, and D for disability. right? D for disability. Now over here, airways, breathing, circulation and disability. So first of all, let me talk about the airways, that how, if the patient is coming, you need to secure the airways, right? In which patient you need to secure the airways, that is the question, right? Same like we have discussed in the trauma also. So first of all, we are gonna discuss the airway. Okay, so in the airways section, first of all, we need to see that if there are some injuries regarding the airways, right? For example, there could be some injury which could have burned the nasal hairs, right? Some inhalational injuries can be there. For example, some person was in the burning area, and he could have inhaled the very hot gases, very hot smoke, right? So due to that, the nasal hairs could have been burnt, right? So those kind of inhalational injuries can be there. So if in case if the patient is having inhalational injuries, then we might need to do some action over here. We need to take some action, and that would be the intubation. So intubation we are doing in this patient for the prophylaxis purpose only. Okay, I'm coming to this section. Second thing, so we need to look for the inhalational injuries in the patient, right? We need to look for any burnt nasal hairs. Okay, look into the nasal cavity and look for the burning areas in the nasal cavity region. Okay, third thing over here is that you need to check for the voice. Okay, try to communicate with the patient, and if the patient voice is having the hoarseness, then also it is a danger sign for the airway section. Then next point over here is that, if the patient is having carbonaceous deposits in the sputum, right? Deposits in the sputum, this is also the danger sign as far as airways are concerned, right? Next point over here is that if the burn is actually involving this area, that is the head area, neck area, right? So head and neck area, face area, okay, this area, if it is involved, then this is the danger sign for the airway, and you need to secure the airways in these kind of patients, okay, by the help of intubation. So if the head, neck or face area is involved, head, neck or face is involved in the burns, so in this case also we need to actually look for the prophylactic intubation to secure the airways in these patients, right? So these are some of the basic things which we need to look into the patient for the evaluation of the airway section. So if any of these things are present, then what you need to do is you need to do the prophylactic intubation. Okay, so what you will be doing, the prophylactic intubation. Okay, why we are doing the prophylactic intubation? Let's say the patient is having any one of these things among the airways section, and person is breathing normally, okay, but still you need to secure the airways by the help of prophylactic intubation. Why is it so? Because later on this same patient might develop the laryngeal edema, okay, and when the patient will develop the laryngeal edema, obviously the patient will not be able to speak. And second thing is, then at that time if you will try to intubate the patient, you will not be able to do so, because at that time the intubation will become very difficult, right? So that's why I'm using the word prophylactic. So prophylactic intubation should be done in these cases. Why? Because later same patients might develop the laryngeal edema, right? So why we are doing the prophylactic intubation? Because later the patient might develop laryngeal edema, right? Okay, no problem. Now let's say this patient, okay, any of the signs are present, you did the prophylactic intubation. Let's say the patient came late to the trauma unit, okay, and already the laryngeal edema have been happened. Now in this case you are trying to intubate the patient, but because of laryngeal edema the intubation cannot be done. So in this case what you will be doing is you should be ready with the needle cricothyroidotomy, which I told you in the yesterday's session also, that needle cricothyroidotomy you will be inserting into the cricothyroid membrane. Okay, the needle, 14 gauge needle should be inserted in the cricothyroid membrane. So in those cases, you might be doing needle cricothyroidotomy. Right, needle cricothyroidotomy. Okay, fine. So obviously, if the intubation fails, right? If your intubation fails, then you have the option of needle cricothyroidotomy. Fine. Okay. Again, now if some patient is coming, okay, but these kind of signs are not present, but this patient is having the burn area more than 40%. So more than 40% total body surface area. I will talk about the how we calculate the total body surface area. So if more than 40% total body surface area is involved in the patient, then also we need to do the prophylactic intubation, right? So let's say that if more than 40% total body surface area is burnt, right, then also we need to do the prophylactic intubation. Fine. So keep this in mind. Okay. So this section is clear. Now next thing is, if the airways are burnt, right? So in this case, what are the phases? There are 3 phases overall, which can be seen in the patient as signs and symptoms. So these phases are, first phase over there is, right? In the first phase, you can be seeing that in the airway section there could be acute pulmonary insufficiency. So patient saturation will be very low. The patient will be having the breathlessness. So patient will not be able to breathe properly. So these are the things which you can see in this particular phase. So in the phase 1, we can talk about the breathlessness. In the phase 1, we can talk about the breathlessness, and the patient saturation might fall in these kind of cases. Okay, and what we are calling this as? We are calling this as acute pulmonary insufficiency. Acute pulmonary insufficiency. That is the first phase of the airways burns, right? Second thing over here is, second phase is the phase 2. In the phase 2, the patient will be having the acute respiratory distress syndrome like picture. So patient will be having the ARDS like picture. ARDS like picture in the X-ray of the patient, right? So the lungs will be having the bilaterally pulmonary infiltrates. Okay, so if you will be seeing the X-ray of these patients, so you will be finding the bilateral pulmonary infiltrates. Okay, bilateral pulmonary infiltrates. Now phase 1 is done. 2, after that phase 3 might be seen in these kind of patient, in some patients. In the phase 3, we are talking about the pneumonia. So the pneumonia might develop in the lungs. Okay, and obviously this is the late stage. So in the phase 3, we might see the bronchopneumonia. In these kind of cases, the patient may have the epithelial damage inside the lungs. So epithelium might get damaged over there. So we are having, in this particular phase only, early stage and the late stage can be there. In the early stage, we are talking about the bacteria development, that is usually the staphylococcus. So in the early stage, staphylococcus bacteria is developing. In the later stages, gram-negative bacteria might develop in this case, because we are talking about the pneumonia, right? So in these cases, what might have been happened, that in the early stage, staph aureus might develop, right? And in the late stage, the patient might develop the gram-negative bacteria. Okay, gram-negative bacteria. So this is also very important. Now next point over here is, if the airways, you have actually secured the airways. Let's say the patient came to your trauma unit and any of those signs were present which we have talked about, then you have secured the airways, you did the prophylactic intubation. After that, after the airways are secured, you need to look for the breathing section, A, B, C, D, right? So in the breathing section, what you will be looking? Look for the hypoxia component in the patient. So in the breathing section, what you will be looking? Okay, so second one is the breathing section. So airways are done. Now the breathing section. Okay, so in the breathing section we'll be looking for, okay, so in the breathing section we'll be looking for if the patient is having hypoxia, right? If the patient is having hypoxia, or if the patient is having, let's say the patient was in the closed room, and in the closed room there was burn, okay, and that trauma happened over there. So if that patient is coming to you, obviously if the burn, if you know the smoke, if the burn is there in the closed room, obviously the smoke will be emitting out from there. So that smoke person will be inhaling again and again, and due to that inhalation of smoke, what could have been happened? Carbon monoxide poisoning can be seen in these patients. Carbon monoxide poisoning can be seen in these patients. And then in some patients, if the burns are very severe, in those cases they might develop the eschar formation. And now what is this eschar formation over here? Now look at this picture. Okay, here you can see the burns are so severe, then they might develop the this kind of picture, that is the eschar formation. Okay, now sometimes we need to actually cut this eschar. Okay, for example, if this area was actually exposed to the burns, so in this area also the eschar formation might have been happened. So in this case, what we will do is, sometimes the plastic surgeon, they will be doing the escherotomy, right? So escherotomy might be done in those cases, because if the eschar formation is present in this particular area, in the chest area, then, or in the thoracic area, then what could have been happened? This will restrict the breathing, right? The person will not be able to breathe properly. So that's why escherotomy can be might be done in those kind of cases, right? So it can cause a respiratory compromise. Fine. So after checking for the breathing component, we need to look for the circulation component. So airways are done, breathing is done, and then we should look for the circulation component. In the circulation component, we are talking about the response from the body side, right? So what is the response from the body against the burns, right? The burns happen to the patient. How the body will be reacting against this kind of process. So over here generally we are talking about the inflammatory response. And this inflammatory response is actually depending on the extent of the burn, that how severe the burn is. Accordingly, inflammatory response will be seen in the patients. So it is directly proportional to the extent of burn, right? If the extent of burn will be more, if the burns will be more, obviously if they are covering more area, then obviously the inflammatory response will also be much stronger. So if I'm talking about inflammatory response, what basically I'm talking about, okay, what exactly I'm talking about if I'm saying that inflammatory response, what do I mean by that? Okay, before coming to that, if the patient is having less than 10% body surface area burn, less than 10% total body surface area, okay, if the burns are involved less than 10% total body surface area, then we are saying that the patient will be having localized immune response. The patient will be having localized inflammatory response. Localized inflammatory response. If the patient is having more than 10% total body surface area, if the patient total body surface area has been burned more than 10%, then in those cases generalized, or I would say systemic inflammatory response. So generalized inflammatory response will be activated. Generalized inflammatory response would be seen in such patients. So guys, now the circulation part is very important, because these kind of patient might have the evaporation from the body, and due to that evaporation the patient might be having severe dehydration, and due to that person might be going into the shock, right? So this is very important to know that how this inflammatory response is actually working in the body. So if obviously looking over here, you can see that if the more than 10% area is actually involved, then generalized inflammatory response can be there, or if it is less than 10%, then only the local portion is actually getting involved. So over here what happens is, let's say the burn patient comes, right? In this patient there was burns, right? This will actually activate the inflammatory response. This will activate the inflammatory response. If more burn area will be involved, more inflammatory response will be there. Due to the activation of this inflammatory response, it will cause the vasodilation. It will be causing the vasodilation, right? And if the vasodilation will be happening, what will happen? Okay, what will happen actually? then whatever component is present inside the blood vessel, it might leak out from the blood vessel, right? I'm saying, let's say this is the blood vessel, right? Let's say this is the blood vessel, okay? And what is happening? The inflammatory response has been activated, right? Usually it is activated by the inflammatory mediators. Usually it is activated by the inflammatory mediators. What mediators we are talking about? Mediators like histamine is there, prostaglandins or leukotrienes. Okay, these are the inflammatory mediators, right? So these inflammatory mediators will be causing the vasodilation in the blood vessel. As the vasodilation will happen, whatever content is present inside the blood vessel, it will try to leak out into the third space. Actually, with the vasodilation, the capillaries are also becoming leaky, right? So the capillaries are also becoming leaky. Capillaries are become leaky over here. So they will be losing their content. So blood vessel will be losing their content. So what could have been happened over here is that this patient blood vessel became leaky. So whatever content is present inside, okay, whatever content is present inside, okay, this will start to leak out from this capillary. Fine, it will start to leak out from the capillary, and as the content will be leaking out from the capillary, what will happen? The patient might be losing the fluid from the body. Okay, it will be accumulating in the third space. So edema will be seen in these patients, but the patient might go into the shock, right? So that is the idea. That's why the vasodilation can cause the shock in the patient. So basically, one more very important component is actually leaking out from the capillary, and that important component is the colloid. That is your protein. And basically, which protein I'm talking about? That is the albumin protein. So again, guys, there was a burn patient, right? Inflammatory response might have been activated in this patient. In this patient, inflammatory mediators, which are like histamine, leukotrienes, prostaglandins, right? These kind of mediators, what they did is they did the vasodilation in the blood vessel. After doing the vasodilation, with that the capillaries will become leaky. And if the capillaries will become leaky, mainly the albumins and the fluid, right? The albumin will be leaking out, and albumin is actually holding the fluid inside the blood vessel, right? Because of the oncotic pressure, right? Or colloid osmotic pressure. If the albumin will be lost from the blood vessel, then fluid will also be lost from the blood vessel, and due to that the patients might be having the dehydration, right? So due to the capillary, because the capillary is becoming leaky, what will happen is that these kind of patients will be losing the albumin, right? So albumin will be lost, right? As the albumin will be lost in these patients, the patient will be losing the fluid also, right? So the fluid will go into the third space. Fluid will go into the third space, okay? Or you can say the extravascular space, okay? Or you can say it will go into the extravascular space, right? Okay, then what will happen? Now imagine this is the blood vessel, guys. In the blood vessel there was a lot of albumin and fluid, right? Albumin, now the blood vessels have become leaky, right? The blood vessels have become leaky, and now the albumin will be lost from these blood vessels. If the albumin will be lost from these blood vessels, then fluid will also be lost from the blood vessels, and now this is the extravascular space. Now in this extravascular space, the albumin will be coming and the fluid will be losing in the fluid will be coming out in the extravascular space, that is also called as the third space. So usually we are saying third space loss will be seen in this patient, right? Obviously if the fluid is actually getting lost from these blood vessels, then obviously the fluid volume is decreasing in these kind of patients, right? And that's how the blood pressure will also be dropping. The patient might go into the shock. With that, we can say the patient will be having severe dehydration, right? Due to that, due to the vasodilation, the patient will be having the evaporation, and that is also the factor uh, because of which the patient might go into the shock. Okay, so that is basic pathophysiology behind the shock in the burns patient. Okay, so that is the thing over here. So that's how the patient might be having the evaporation due to the vasodilation. The patient might be having the evaporation also. Okay, and because the fluid is getting lost into the third space, due to that we can say the patient will be having the dehydration, right? So that is the pathophysiology behind the shock in the cases of burns patient, right? So that is very important. Okay, once we have talked about this particular process, then we can talk about the treatment part, right? Treatment part means if the patient is having shock, right? Obviously, what you are giving usually, what comes in your mind if you are thinking about the shock patient, fluid volume is lost, so you are thinking about giving the fluids to this patient, right? Obviously, again, same thing I told you yesterday also, right? Cannulate the patient on both the sides, minimum 18 gauge cannula, start the fluids, right? Start the fluids. Now over here, the catch point is whether you will give which fluid you will be giving basically. So we are giving the crystalloids. In crystalloids, what you are giving? Shall I give normal saline to this patient, or should I give dextrose to this patient? Should I give ringer lactate to this patient? So answer to this question is we should be giving the ringer lactate to this patient, which is also called as the Hartmann solution. Okay. Now why is it so? We'll talk about this. So guys, what is the management? Okay. So the management for such cases, we saw that there was dehydration, evaporation, the patient might be in the shock, right? Patient BP, you will be checking the vitals of the patient, obviously. Patient came to your trauma unit. So you will be checking the vitals, obviously. BP will be on the lower side because of this pathophysiology. And you will now thinking about the, how to overcome this particular shock. So in these cases, you will be thinking of giving the fluids. Which fluid I told you? Ringer lactate or RL, which is also called as the Hartmann solution. You will be giving to these patients. Now, if you are giving the IV fluids, right, you are thinking to give the IV fluids, right? So the uh, most ideal IV fluid in these burns patient would be the ringer lactate. Okay, would be the ringer lactate. This is also called as the Hartmann solution, right? Hartmann solution, right? You can see over here the packet of the ringer lactate. If you will see, if you're working in the in any kind of hospital, right, very commonly you can find this in the emergency or in the ward or anywhere in the hospital. You can easily find this ringer lactate bottle. Okay, very commonly the patients are actually taking this, right? We are giving the fluids to the patients. So this is the uh, RL. Okay, you can see 500 ml. So what you can see over here is that what is the content of the ringer lactate. Okay, that's why I'm showing you this. And in the in today's examinations, okay, they are just giving you the photos. Okay, and you need to identify what kind of fluid they are talking about. Is it normal saline or is it dextrose, like that? So ringer lactate is containing, you can see the sodium chloride. Okay, you can see the sodium chloride, the lactic acid, okay, the potassium chloride and the calcium chloride in water. Okay, in water it is containing the KCl, which is the potassium chloride, calcium chloride, and it is containing the lactate, right? So this is the solution, right? And sodium lactate. So this is the solution for the ringer lactate. Now why we are giving this in the burns patient? Because in the burns patient there is a tendency for the metabolic acidosis, and ringer lactate helps us in treating the metabolic acidosis also. So that's why, because it prevents the metabolic acidosis, that's why it is the ideal IV fluid choice in the burns patient. Okay, so we can overcome the dehydration part also, and we can overcome the metabolic acidosis part as well at the same time, right? So that is the motto behind giving the RL fluid or the Hartmann solution in the burns patient, right? Okay, so once we are clear with this, right, once we are clear with this, let's move forward. And if the patient is coming, okay, one more thing, with the IV fluids we can give the colloid also, because I told you albumin is getting lost from the blood vessel. So you might be thinking that albumin, we can give the albumin also, right? Or albumin is actually the colloid only. Okay, 4.5% albumin is the colloid only. So shall we give colloid in this patient? Yes, we can give colloid in the patient, but not in the initial 12 hours, right? Because in the initial 12 hours of the burns, right, the patient will be losing, the patient's blood capillaries will be losing the albumin very quickly. So that's why if you are giving the albumin to these patients in the first 12 hours only, then whatever albumin you will give, it will be leaking out from the blood capillaries, right? What I'm saying is, I told you guys that over here, what I told you, that whatever albumin, let's say this was albumin, right? This was albumin. Whatever albumin you were giving, it was coming outside. right? So in the first 12 hours, if you are giving in the first 12 hours, if you are giving the albumin to this patient, same story will be happening to your albumin also. It will come in the blood vessel and it will be leaking out. It will come in the blood vessel and it will be leaking out. So there is no benefit in giving this colloid or albumin to this patient. So that's why don't give the colloid for the first 12 hours. Okay, after the 12 hours, you can start with the colloid also, right? So initially we are giving the ringer lactate only. After the 12 hours, you can start the colloid also, right? Because this process will be slowing down after 12 hours, right? Okay, understood. So IV fluids, you can give the colloids also, first point. Second, you can give the colloids, right, which is 4.5% albumin, but the catch point over here is not in the initial 12 hours, not in the initial 12 hours. Okay, please remember this, very important point, and this point has been asked in the questions also many times, right? Now once we are done with this, let's say the patient is coming to your trauma unit. Okay, so I told you first thing is less than 10% total body surface area is involved. One patient is there, second patient is there, more than 10% total body surface area is involved, right? Okay, now inflammatory response, I told you how it is working, how it is causing the dehydration, and how is it causing the evaporation, and how it might cause the shock in the patients. Which fluid we should go, you should be giving, that also I told you. Now if in the children the patient is coming with the more than 10% burns, okay, so what I'm saying is, if the child comes to your trauma unit with more than total body surface area 10%, okay, in child I'm saying, right, and one more adult came now, and in this adult more than 15% total body surface area is involved. So in these cases, you will be saying that in these cases the patient might develop the hypovolemic shock. Okay, the patient might develop the hypovolemic shock. Now initially in the burns patient, the patients will be having the hypovolemic shock. Later on these patients might develop the septic shock. I will tell you the causes of death in the burns patient also. So always remember that dehydration is a very important portion, and we need to treat the dehydration. We need to give the fluids in the burns patient. That is very, very important, and it depends on how much body surface area has been burned in the patients, right? Okay, so in case if more than 10% total body surface area in child and more than 15% in adult, that will be considered as that might be saying that the patient might be having the hypovolemic shock. Now how will you do the fluid management? Okay, what fluid we are giving, we have understood that. How will be doing the fluid management in the patients, right? Fluid management, right? So for the fluid management we are having some formulae over there, but before that, let's say if the patient is there and they are having the small area of burn only, small area of burn, another patient is having the more area of burn, large area of burn, let's say more than 10 to 15% total body surface area burn. Okay, how will you manage these patients? So if the patient is having small area of burn only, then you might give them oral fluids also, right? You might give them oral fluids, but the main thing over here is please mix the salt in it, because during the evaporation they might lose the salt also. So that's why oral fluids we are giving, but mixing the salt in it, and that hypertonic solution you can give to the patient if the patient is having minor burns, right, small area burns. But if the patient is having more than 10 to 15% total body surface area burns, then in those cases you must give the IV fluids. In those cases you must give the IV fluids. And how you are giving the IV fluids? We are giving them according to a very important formula, very famous one, very popular one, that is the Parkland formula, right? According to the Parkland formula. Now what is the Parkland formula? Okay, let's talk about that as well. What is the Parkland formula and what it says? In MCQs it is tested very, very commonly, so please listen to this section very, very diligently. Now look over here. In the Parkland formula, we are saying that according to this formula, we can calculate how much IV fluid should be given. So 2 into body weight of the patient in kg, body weight of the patient in kgs, into total body surface area which is burnt. So this is the formula. Okay, this is the Parkland formula. According to this formula, we can actually calculate how much IV fluid should be given in the patient. Earlier it was 4 into body weight into total body surface area burnt, but now it has been modified. Okay, that now they are saying it is 2 into body weight into total body surface area burnt. So now if the question is coming, please mark this answer. Next thing over here is how actually we are giving this fluid. For example, the patient is there who is having 100 kgs of weight, right? Patient is there, came to your unit, and patient weight is 100 kgs, right? And you calculated the how much body surface area has been burnt, and it came out that 18% total body surface area was burnt. That was 18% total body surface area burnt, right? And now they are asking you how much IV fluid you should be giving. So simple guys, just apply this thing in this particular formula. So 2 into body weight is 100 kg multiplied by total body surface area burnt, that is 18. Your answer came out to be, that is your 3600 ml, right? So that much amount of fluid you should be giving in this patient. Okay, now 3600 ml, how you will give this fluid to the patients, right? So look over here, right? So the amount of fluid which should be given in the first 24 hours, how you will be actually managing this. So half of the fluid you should be giving in first 8 hours, and the rest of half of the fluid you should be giving in next 16 hours. So I am saying that half of the fluid it should be given in first 8 hours, should be given in first 8 hours, okay, and next half of the fluid it should be given in the, so second half of the fluid, second half should be given in next 16 hours, should be given in next 16 hours. Okay, fine. So you are having 24 hours. So divide this 24 hours day, okay, into two parts, 8 hours and the 16 hours. In the 8 hours, first half of the fluid you will be giving. In the in the 16 hours, second half of the fluid should be given. So 3600 ml, let's say this patient only, 100 kgs patient was there, 18% total body surface area was burned. This patient, you calculated that 3600 ml should be actually given to this patient. So 36 divided by 2, it came out to be 1800 ml. So 1800 ml, half of the fluid, right? So 1800 ml should be given. So what I'm saying is that 1800 ml should be given in 8 hours, and next 1800 ml should be given in next 16 hours. Okay, understood? So that's how we should be giving this IV fluid to the patient in initial 24 hours, right? Okay, fine. I think that has been cleared how to apply this for Parkland formula. Usually they are asking you these simple questions, right? Okay. Now we shall talk about if the child is coming to you with the same question. Okay, so this patient, this Parkland formula I told you for the adults. Okay, this was for adults, this was for adults, right? If they are saying children, then formula is having a little modification only. Okay, that 3 into body weight in kg into percentage of total body surface area burnt, total body surface area burnt. Okay, so this is the formula for the children. Okay, so it's the same thing you can apply over here, but main catch point over here is in the children. I told you that what is the IV fluid you will be using in the burns patient, that was ringer lactate, right? In the initial 12 hours you should not be using the colloid, that is albumin. In the after the 12 hours you shall be using the colloid also, that is you shall be using the albumin also. Now if the children is there, if the child is presenting to you with the burn, right, then in those cases with the ringer lactate you should actually add the dextrose containing fluids also. For example, DNS can be added. So in the children, in the IV fluid if you are giving, then with the ringer lactate you can add the dextrose containing fluids also, that is DNS, for example, right? So ringer lactate, along with that you might add the dextrose containing solutions also. Now over here, why we are giving this? Because we want to avoid the dehydration part. So for the maintenance therapy, for maintaining fluids, for maintenance we are giving this. Okay, for maintenance purpose we are giving this. Now how to give this particular thing? So there is also a formula, very easy one. So 100 ml per kg for first 10 kgs, for first 10 kgs in 24 hours. Okay, now 50 ml per kg for next 10 kgs, next 10 kgs in 24 hours, and 20 ml per kg, okay, for every kg after 20 kg in 24 hours, right? So what do I mean by that? Let's say the patient weight was 25 kgs. Let's say the patient weight was 25 kgs. So just divide it like 10 plus 10 plus 5, right? So for the first 10 kg you will be giving the 100 ml. For the next 10 kg you will be giving the 50 ml. So very easy, 100 plus 50 plus, for the last part, that is 5, I mean 20 ml kg for every kg after 20 kg. So after 20 you are having the 5 kg. So 5 multiplied by 20, right? So it will become 100 plus 50 plus 100, so it became 250 ml, right? So that's how we can calculate how much amount of dextrose can be given along with that, right? So I hope you are clear with this formula. Fine. Okay, so now once we are clear that which fluid should be given, IV fluid, that is the ringer lactate Hartmann solution, right? Along with that, in the initial 24 hours albumin should not be used. After that it might be used. In the children, dextrose containing solution might be added with the ringer lactate. Once we are clear with this, then we shall talk about how to calculate the, if we are giving the colloid, if you are giving the 4.5% albumin to the patient after 12 hours of the burns, then how to calculate it. So let me talk about the colloid also. If we are giving the colloids to the patient, right? If you are giving the colloids to the patient, then how we are giving that? So let me talk about that as well. In case if you are giving the colloids to the patient, that is 4.5% albumin you are giving. I told you already that in the initial 12 hours, because the leaking process is becoming very quick, so that's why in the initial 12 hours it should not be used. I'm saying after 12 hours you are using this, let's say. So how to calculate? It is calculated by a formula, Muir and Barclay formula. Okay, Muir and Barclay formula. So what they say is that, in total we are giving the 6 portions. In total we are giving the 6 portions of the albumin. Okay, first question, how many portions should be given if you are giving the albumin to the patient? Then they say that one portion, how to calculate one portion? One portion equals 0.5 into body weight in kg, multiplied by total body surface area that has been burnt. Okay, you might have confusion regarding this TBSA, total body surface area. I will tell you shortly what is total body surface area, how we are calculating that. I will tell you, just wait for this moment. But I told you that I am saying colloids we are giving not in the initial 12 hours, after that we are giving. So after that, how to calculate? There is a formula that can be calculated by Muir and Barclay formula. What is this formula? This formula says that 6 portions of the colloid should be given. Out of those 6 portions, how to calculate these portions? One portion is having this formula. Okay, so 0.5 into body weight into total body surface area burned. Simple formula, just apply the values, the person weight will be given, total body surface area will be given, and just you need to apply this formula. Now, how you will give this particular thing? For example, in the Parkland formula also I told you that in the first 8 hours you will be giving the half of the fluid, in the next 16 hours you will be giving the rest of the half of the fluid. Here also, how we are calculating, how we are giving these 6 portions. So we are giving these 6 portions in the 36 hours. We are giving these 6 portions in the 36 hours. Okay, in the 36 hours we are giving this. Okay, so just break it in the 12 12 12. Okay, just break it in the 12 hours plus 12 hours plus 12 hours, right? It became 36 hours. Now we are giving 3 portions. We are giving 3 portions in the 12 hours. Okay, every 4 hours we are giving this. So every 4 hours, right? Every 4 hours we are giving one portion, and we are giving it in 12 hours. Okay, so in first 12 hours we are giving 3 portions with the gap of 4 hours, right? So let's say now we give one portion, after 4 hours another portion will be giving, after 4 hours another portion will be given. So in the first 12 hours we'll be giving the 3 portions, then followed by 2 portions in the next 12 hours. It means with the gap of obviously 6 hours, right? So every 6 hours in 12 hours, right? So in the first, so in 36 hours we should be giving the 6 portions. So 12 12 and 12. So in the first 12 hours you have to give 3 portions, in the next 12 hours you have to give 2 portions, in the last 12 hours you have to give, you know, one portion, that is the rest one, right? So 3 portions, 2 portions, 1 portion. Now over here, so we are left with 1 portion, right? So that 1 portion which has been left out, that has to be given in last 12 hours, right? So remaining portion in last 12 hours. Okay, so that's how we are giving the portions. Fine, there is no confusion, I hope. So again guys, burn patient came to you, check for the airways, check for the breathing component, check for the circulation component. In the circulation component, you have find out that patient is in shock. Let's say the patient was having the more than 10 to 15% total body surface area burn. Then in those cases, you should be giving the IV fluids. Which IV fluid should I be choosing? I should choose the crystalloid. In the crystalloid, what should I be choosing? I should be choosing the ringer lactate. It is also called as the Hartmann solution. With the ringer lactate, how to calculate what amount of fluid should I be giving? So then it is calculated by the Parkland formula. Parkland formula says that first half of the fluid should be given in the first 8 hours, rest of the fluid should be given in the next 16 hours. Then in the cases of children, you might add the dextrose containing fluids along with the RL for the maintenance therapy. And in cases if in the initial 12 hours you should not be giving the albumin or the colloid, but after the 12 hours, after completion of 12 hours, you might start with the albumin also. How to give the albumin? In the 36 hours, you should be giving the 6 portion. How to calculate that 1 portion? That is 0.5 into total body surface area burned into body weight. Okay. And after calculating this, that is the formula for 1 portion, right? And the 6 portion you have to give actually as a colloid. So how to give 6 portions? Just divide the 36 hours into 3 parts, 12 hours, 12 hours and 12 hours. In the first 12 hours, give 3 portions. In the next 12 hours, give 2 portions. In the next 12 hours, give rest of the portion, that is 1 portion. Fine. I hope everything is clear till now. That was a short summary. Now, moving further from here, how to calculate the total body surface area, right? I was emphasizing on total body surface area. So now I am just starting with the TBSI, total body surface area. How to calculate it? Very, very important. So how to calculate this total body surface area? Total body surface area percentage calculation, right? So how to calculate this? Very simple. We are using the Wallace rule of 9. Actually, it is Alexander Wallace. We are using this rule, Alexander Wallace rule of 9. You might forget the Alexander. It is popularly called as Wallace rule of 9. Okay. So what it says, guys, Alexander Wallace, okay, according to him, what is the Wallace rule of 9? So he says that, you know, just very simple formula I'm just telling you. Okay, that's how I remember actually. Just telling you that trick. Okay. However, I will tell you the bookish thing also. So how I remember is, you know, just on one side, just write body part in case if you are making your notes, and on another side, just write the percentage of total body surface area burnt. Okay. Now look how simple will it be. Remember. Okay. And believe me, if the burn question is coming in your exam, okay, 70 to 80% chances are there that that question will come from the Wallace rule of 9. They will be asking you how to calculate the total body surface area, right? Or they might ask you that, you know, what amount of fluid should be given to this patient. Obviously, to calculate, you need the Parkland formula, and Parkland formula says 2 into body weight into total body surface area burned. So for that question also, you need the total body surface area, and total body surface area you will be calculating from this formula, that is the Wallace rule of 9. So that is the importance of this formula, right? So, you know, on one side just write body part, on another side just write total body surface area which has been burned. Very simple. Total body surface area burned, just remember the 9 because it is Wallace rule of 9. Okay, that's why he named this Wallace rule of 9. Just remember this 9, so you don't need to remember anything. On the body part, start from the head only, right? So in the head, write head and neck. First of all, just write head and neck. Head and neck. Okay. After the head and neck, okay, just remember we are having the right upper limb, left upper limb. So write that right upper limb, left upper limb, right? Right upper limb. So head and neck, right upper limb, left upper limb. Then coming to the anterior chest and the upper back. So anterior chest. Then behind that we are having upper back, anterior abdomen and the lower back. Write that anterior abdomen and the lower back. Fine. Then we are left with the legs. So right thigh, right? Let's say this is the leg, right thigh, right leg. Okay. On the another side, left thigh, left leg. So right thigh, right leg, left thigh and left leg. Okay. So what portions we have covered? We have to cover the whole body. So head and neck area, then right upper limb, left upper limb, anterior chest, upper back, anterior abdomen, lower back. Okay. Right thigh, right leg, left thigh, left leg. Okay. We have left with the genitals part, and at last just write the genitals. Okay. How easy will it be now? Just remember. Okay. On the other side, you don't need to remember anything at all. It is the Wallace rule of 9. The rule is only saying 9, 9, 9. So just write 9 over here. Just write 9. 9%. 9%. It is also 9%. This is also 9%. Everything becomes 9. Okay. That's how I remember. Okay. This is also 9%. This is also 9%. Just genitals are 1%. Just genitals are 1%, right? So if you remember like this, it will become very easily. I'm just repeating once again. Head and neck, how I'm covering the whole body. Head and neck, 9%. Right upper limb, 9%. Left upper limb, 9%. Anterior chest, 9%. Upper back, 9%. Anterior abdomen, 9%. Lower back, 9%. Right thigh, 9%. Right leg, 9%. Left thigh 9%, left leg 9%, and left with the genitals, that is 1%. If you will calculate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 9 into 11, 99 plus 1, 100. So it became, total became 100%. 100% of the body you have involved. So that is the total. Okay. So that's how whole body has been covered, right? So it is very simple. So that's how you can calculate. Let's say the question came, the patient anterior chest, right? Anterior chest and anterior abdomen has been burnt. So anterior chest contains 9%, anterior abdomen 9%, 9 plus 9, 18, 18% is the total body surface area burnt, right? Now accordingly, if they're asking you what amount of colloid you should be giving, what amount of ring IV fluid you should be giving, you can calculate easily, because now you know the total body surface area. They will be giving the weight of the patient as well, and now you can easily calculate. Okay, so that is the importance of calculation for the Wallace rule of 9. This is the Alexander Wallace rule of 9. Okay, and if the question is coming in the exam, they are expecting you to calculate the total body surface area with the help of this formula only, that is the Alexander Wallace rule of 9. I hope it became very simple for your convenience part. Okay, just adding the image also over here, right? Okay, just added the image as well. So here also same thing. Okay, so head and neck, it contains 9% actually, 4.5 on this side, 4.5 on the back side, anterior and back. Okay, oh, this is the different formula. This is actually the Lund and Browder chart. Okay, so yeah, this is that formula. So let me just introduce you over here as well. Okay, yeah, so this is the formula. So here you can see the head and neck area. Okay, in total it is containing the 9%. Arms, it is containing the 99% each, right? Then trunk 36% in total, right? Genitals 1% and legs 18%, right? But how I remember with this one. Okay, just covering from head to toe. Okay, 9999, and genitals contain 1%, right? So that becomes very easy to calculate. Okay, once you're clear with this, this is the way, that's how we are calculating the how much total body surface area has been burnt. Okay, I hope this became easy. But if they're asking you what is the formula by which correct estimation can be actually known, then in that cases Lund and Browder chart can be used, right? So they are saying that the best method to calculate total body surface area, that is the Lund and Browder chart. So here you can see the Lund and Browder chart. So these values are confusing, nobody will be asking you this thing, but they had asked you once that which is the best method to calculate total body surface area burnt, that is the Lund and Browder chart. So this chart will be actually pasted on in the burns unit, and according to that they can be estimated. But Wallace rule of 9 is giving the broader idea in our picture that yes, that much amount of total body surface area has been burnt, and why the residents, why the health clinicians are actually calculating the total body surface area, because they have to give the fluids, IV fluids, right? So for giving the IV fluid, they will be using the Parkland formula, right? And for using the Parkland formula, you need the total body surface area burnt. That's why the Wallace rule of 9 comes into the picture. Okay, I hope that is clear. Great. Now, just moving on from here. So let me just document it what I said, that Lund and Browder chart. Okay, what it is telling you actually, it is just telling you that best method to calculate total body surface area. Best method to calculate total body surface area. Total body surface area burnt. Okay, and this is that chart, Lund and Browder chart. Okay, I hope this is clear. Fine. Now just moving on from here, and now I'm moving on to the severity of burn areas. And severity of burn areas can be estimated by the help of zones of the burns, right? So severity of the burn areas, right? So how we can know the severity of burn areas, right? It can be estimated by the help of three things. Three areas, three zones are there actually. So first one is the zone of coagulation, or it is also called as the zone of necrosis, right? The second zone, if we talk about, in the second zone we are saying that this is the zone of stasis, and the third one is the zone of hyperemia. right? Let me just introduce you the picture so that you can really understand what I'm saying. Okay, I will just slide this picture down so that you can understand it. Yeah, just putting it over here. Okay, so here what you can see is that if the burn has been there uh, in any part of the body, right? So this burn might be having the zones. The center zone is called as the zone of coagulation, right? Or it is also called as the zone of cell death, right? Or the zone of necrosis. So over here, direct tissue injury has been happened, and this zone is actually having the irreversible kind of injury. Okay, it is very difficult to actually save that area, right? So irreversible kind of injury has been happened in that, and it usually happens in the center of the bone. As you can see in this picture, this is the zone of coagulation or the necrosis. Now, periphery to that, the orange color which you are seeing, that is the zone of stasis, right? Here the cells are viable but vulnerable. Okay, if you are giving the right treatment to the patient, it can convert into the hyperemic zone, which is the last zone, which is giving the yellow, which is given in the yellow color, zone of hyperemia. Here the tissue recovery are very nice. So if the zone of stasis says that if the proper treatment has been given, it might convert into the zone of hyperemia. If the treatment has not been given adequately, then it might convert into the zone of coagulation. So it is kind of a in between, right? It is kind of a sandwich. So in which zone of stasis, if with proper treatment, it might convert into zone of hyperemia. With improper treatment, it might go towards the zone of coagulation, right? So that is the importance of knowing the zones of burns over here, that has been asked repeatedly. So just writing it over here in the zones of coagulation, what we are seeing, basically the cells has been died. Okay, and this is the most severe injury, most severe burn portion. Okay, and here you can see that the injury which is happening, that is irreversible. So irreversible injury, irreversible injury, right? In the next zone, that is the zone of stasis, that is peripheral to the zone of coagulation. As you can see in this picture, this is the orange color line, orange color area, which is shown by the zone of stasis. In this zone of stasis, I told you that if the proper treatment has been given, might convert into the zone of hyperemia. If not, then might have converted into the zone of coagulation also. So here in the zone of stasis, I can say that reversible, this is a reversible injury. This area might be salvaged, and here the patient might have been experienced the variable degree of vasoconstriction. Okay, the patient might have the vasoconstriction in this area, and due to that, ischemia might be seen, right? And due to that, ischemia might be seen in this patient. Now, in the zone of hyperemia, you'll be seeing, obviously it is the reversible injury. Reversible injury has very good chances of survival of this portion of the tissue, and in this kind of particular zone of hyperemia, the vasodilation can be seen, and due to the vasodilation, the color will be converting into red color. So that's why this area is called as the hyperemic zone, right? So over here, that is the hyperemic zone, right? Fine. So because the injury will happen, I told you the inflammatory mediators will be causing the inflammatory response and all. These are the inflammatory mediators. In this image, they are showing you inflammatory mediators. So these are the inflammatory mediators like histamine, prostaglandins, leukotrienes, right? Interleukin 6, interleukin 1 beta, TNF alpha and all. These are the things, right? So that is the thing. I have told you about the systemic inflammatory response also, right? If the burns are, involving much area of the body. Okay. Once we have talked about the zones also, now I'm going into the degrees of burns. So for the degrees of burns, okay, you just need to see this picture. Okay, so just a sec so that we can talk about the degrees of burns. Yeah, fine. So here what I can see is that there are several degrees of burns. Okay, so classification by the depth of burn. So here we are talking about the degrees of burns. Okay, so degrees of burns, right? So we are having the usually 4 degrees of burns: first degree, second degree, third degree, and the fourth degree. In the first degree, that is very superficial kind of burn, right? in the second degree, we are talking about the uh, partial thickness burns and the partial thickness burns, which means the partial dermis has been involved, or the upper dermis, which is the papillary dermis, has been involved in the second degree burns. Next category is involving the epidermis and the reticular dermis. In the next category, that is the third degree, they are having the full thickness burns, and the fourth degree having the full thickness burns, right? So over here we are seeing that superficial first degree burns. Okay, so here you can see superficial first degree burns, that is involving the epidermis, right? And if you will apply the pressure on that area, they are showing the blanching erythema, right? They are showing the blanching, and they are usually very painful, right? And they are actually healing without scarring, and 5 to 10 days, in 5 to 10 days healing will be there. For example, sunburn is the best example. So in the sunburn, what is happening? The area is becoming that, the exposed area is becoming hyperemic, red in color, but after 4 to 5 days or after a week or so, the without scarring or without any kind of marking, without any kind of scarring, the tissue is becoming better, right? The tissue has been healed properly. If you come towards the second degree burn, right? In the second degree, you're talking about the two types: superficial partial one, superficial partial thickness, and the deep partial thickness. In the superficial partial thickness, upper dermis, that is the papillary dermis, has been involved. Papillary dermis along with the epidermis, right? Along with the epidermis. And in the lower and in the deep partial thickness, obviously epidermis has been involved. Along with that, reticular layer of dermis is also involved, right? Reticular layer of the dermis has also been involved. Then you can see the blister. Blister is very important. They generally ask you blister formation is seen in which degree of burns. So that is the partial thickness second degree burn, right? Partial thickness second degree burn. And or in fact, very specific answer will be superficial second degree burns, right? Okay. They are also very painful, and they might be healed on their own, but without scarring, but they will be taking much more time. Obviously, they will be taking around 2 to 3 weeks or more than that. Okay. Now, second degree burns, but the deep category, I mean epidermis is involved. First of all, first degree burns only the epidermis. Then second degree burns, after the epidermis, obviously the epidermis will be involved. Then they might involve the superficial layer of dermis also, that is the epidermis plus partial layer, epidermis plus papillary layer. In the second degree full thickness burn or the deep thickness burns, in that case epidermis plus papillary as well as reticular dermis might be involved. Then comes the third degree. In the third degree, you can see the full thickness burns. Okay, in the full thickness burns, and in this one you can see the epidermis is involved, whole dermis is involved. With that, subcutaneous tissue is also involved. Subcutaneous tissue is also involved in this case, right? So that is very important to know. Next thing is, you can see the appearance that can be white or blackish or brown, that is non-blanching. Decreased sensation, there is no pain, they are painless, right? They are painless. And in the deep partial thickness burns also, they are actually painless, but they might show pain in the pricking sensation. By the help, if you are pricking them, then they might be having pain. Otherwise, the nerve endings has been burnt off, right? And due to that, sensory receptors has been destroyed. Okay, that's why they don't feel pain. If you will be giving pain stimulus to the third degree burns patient or the fourth degree burns patient, they will not be showing any kind of reaction, because the burns due to the burns, the nerve endings has been burnt off, and that's why they don't feel any kind of pain over there. So they are completely painless. So remember that they are asking you in these kind of things in the MCQs also, that if the patient is having the pain in the third degree or fourth degree burns, right? So answer is obviously no, they are not having the pains. So third degree patients, they are having the contractures, they are healing by contractures, and more than 8 weeks they will be showing the scar formation. Okay, with the scar obviously they will be going, right? And here these kind of patients need the help of the plastic surgeon, because they will be releasing the contractures. Okay, fine. Then you are having the fourth degree burns over there, that is very, very bad burns. The necrosis will be happening. In some cases they might need the amputations as well, right? So we need to remove that part of the area of the burn which has been completely necrotized or has been involving the gangrene. Okay, so that would be the 4th degree burns. Fine. So just documenting that as well. So in the 4th degree burn, what you will be seeing, 4th degree burn, because that is not involved over here. 4th degree burn, that is not written over here. In the 4th degree burn, usually they are involving everything: epidermis, whole dermis, subcutaneous tissue, some muscles, and sometimes bone also. So what is involved? Epidermis plus dermis plus subcutaneous tissue, right? Along with that, muscle might be involved. In some cases, bone might be involved as well. Okay, now these are 4th degree burns. So obviously you know what is the prognosis. Prognosis would be very, very bad, right? So usually in these kind of patients, if you talk about the 4th degree, what will the color? Usually they are very blackish in color or the pale in color. Do these kind of patient will feel pain? Obviously not. They will be having the painless sensation, right? Okay, so once we understood this, now I am moving on to the next section, and that would be the overall picture of the burn, actually, that how the patient can be managed. So once again, let's look over this picture. So till now what we have talked about, the burn patient came to your trauma unit. Obviously you will be looking for the ABCD component, right? You will be looking for ABCD component, right? So ABCD, that is the airway, breathing, circulation, and disability component. You will be seeing in them. Then first thing. Second thing, if the patient is coming, okay, for example, if some patient is coming, for example, hand burn, okay, and came to your casualty, then wash the wound of this patient. So wash the burnt area. Okay, and please remember, you will be washing this burnt area with the room temperature only. Okay, with the room temperature water only. Okay, room temperature water only. Okay, please remember this. Then if the patient is having, let's say, superficial 2nd degree burns, right? So in those cases, obviously you will be seeing the blister formation. So don't burn the blisters, or I will say don't burst these kind of blisters, because they will be causing much more pain, right? So don't burst the blisters. In case if it is 2nd degree burn, don't burst the blisters, right? Next thing over here is, you should be giving what? You should be giving the IV fluids to the patient, right? So give the proper IV fluids. Which IV fluid you will be giving? Ringer lactate. Okay, then if the patient is having the burns, okay, in some patients they will not be able to eat also, right? And in some patient there are chances of distension of the stomach and distension of the abdomen. So in those cases you might do the insertion of nasogastric tubes, or nasogastric tube, or also called as the Ryle's tube, right? So in those cases you can use that NG tube or Ryle's tube, because it is having two benefits, guys. First is that you can cause the decompression of the abdomen. You can cause a decompression. Second benefit is that with the help of decompression, you can get rid of that particular distension part. Second thing is, you might feed the patient also. So feeding can be done through the Ryle's tube only, right? In case if the enteral feeding is not possible, you might give the, just insert the NG tube, very easy to insert it, and then you can start the feeding through the NG tube only, right? What kind of diet, if I will be asking you, what kind of diet you would like to give to these patients? Now you'll be saying the patient was losing the proteins or albumin, so high protein diet. Okay, so no need to think much in this case. Obviously high protein diet the patient will be taking. Now if the patient is having formation of eschar, right? I told you what is eschar formation. So eschar formation is that, thickish kind of a layer of the skin has been formed in the patient. So if the eschar formation is there, obviously the plastic surgeon will be doing the escherotomy. They will be actually cutting that eschar, right? Okay, fine, and removing the gangrenous part of the skin. Okay, fine. So if the eschar formation is there, you need to do the escherotomy. Now if you will be going, let's say if you are having a posting in the surgery department, or if you are an intern in the surgery department, usually if you will be doing the internship in the surgery department, then what your job will be? in the early morning you need to take the vitals of the patient. If you are posted in the surgical wards, then you need to take the blood samples of the patient, and after that you will be helping your residents in the dressing of the patients. Now, if you are doing the dressing of the patient, obviously the burn patient also will be present, some here and there. The burn patient might also be there in your surgery department, so in the surgical ward. So what could have been seen? You will be doing the dressing. So in the dressing part, what kind of dressing can be done in several degrees of burns? Let's talk about that also. So guys, let's say here are the stages. Okay, so stages of the burns, and here you can write the management part. Okay, so for an example, let's say that there is first degree burn. Okay, in the first degree burn, you don't need the dressing, just expose the wound, clean it off, and that's it. So in the first degree burn, you just need to expose the wound. Okay, just need to expose the wound, just clean it off superficially and all. Okay, you don't need the dressing actually. If the patient is having obviously second degree burn, here you need the dressing. Okay, if the second degree burn, if it is superficial only, it means epidermis and the papillary layer of the dermis has been involved. In those cases, we are using the Vaseline or the paraffin gauze. So if it is superficial, then we are using the paraffin gauze dressing, paraffin gauze or Vaseline gauze dressing, right? Vaseline gauze dressing. Okay. Now the benefit of using this paraffin gauze or Vaseline gauze is it is actually sticky in nature, right? Actually, it is having a the Vaseline, right? What is the nature of Vaseline? Okay, so you will be having these kind of gauze pieces. When you will be doing the dressing of these kind of gauze pieces and you will be doing the dressing over it, after that, let's say next day when you will be opening up the dressing, okay, these gauze pieces will not be sticking to the wound actually. Okay, so you can easily remove them. Otherwise, what could have been happened? They might be sticking to the wound, and it will be very difficult to remove those kind of gauze pieces. So that's why special kind of Vaseline or the paraffin gauze is actually used for the dressing of the superficial second degree burns. Okay, if some of you might have been posted in the surgery department, you might have seen it as well. Now, next thing, second degree deeper burns, second degree deep burns. Okay, which layer will be involved over here? That will be the epidermis plus superficial dermis, that is your papillary and reticular dermis as well. So over here, what kind of dressing? You will be using the collagen dressing. Okay, you'll be using the collagen dressing, or you might use the hydrocolloid dressing as well. Okay, just for the examination purpose, I'm telling this hydrocolloid dressing or the collagen dressing, in case if they're asking you what kind of dressing can be used in the deep second degree burns, right? Then this thing is clear. Okay, then if they're asking you the Hesher formation, I told you the hysterotomy should have been done over there, right? And please do remember that your job will not be finished by doing the dressing part. You actually need to change the dressings in a regular period of time, because the infection might develop in these kind of dressings, right? So always there is a risk of secondary bacterial infection, and usually the most commonly we are seeing the Pseudomonas is actually growing in these kind of dressings, Pseudomonas bacteria. And usually how to identify the Pseudomonas bacteria in the dressing? First of all, a very unpleasant smell will be coming from the wounds. Secondly, the Pseudomonas might stain the dressing with the green color. So if you are seeing the greenish kind of pattern in the dressing color, and special unpleasant kind of smell is coming from that dressing, then obviously you might think of the Pseudomonas dressing. So it is very common in the burns patient. So that's why proper hygiene, proper dressing care should be done in the burns patient, right? Okay, so once we are clear with that, let's move on to the next point. Which kind of special, which kind of antibiotics, which kind of drugs we can give to these kind of patients while treating these burns patient. Obviously, we have talked about the IV fluid part that will take care of the shock and all. But here, let's say the superficial burn was there. Okay, what kind of cream you can apply over here, or some kind of antibiotics you can give over here. So in this case, we might use some of the drugs. Okay, so some drugs or some topical applications. I'm just telling you. First of all, we are having silver sulfadiazine, which is used very commonly also. Silver sulfadiazine. Okay, and that is 1%. It is used very commonly. Okay, you might have seen as well. So most commonly used. Okay, and it is also causing the discoloration of the dressing part. Okay, it is also causing the discoloration of that particular area. Okay, that is kind of, you can say, side effect or something else, but that is kind of a negative point over here. It is used very commonly, and it is good against the bacteria also. It is good against the pseudomonas bacteria. It is working very good against the gram negative kind of bacteria also. So this is giving the bacterial protection. But actually, whenever you are actually applying it, it is actually staining the black color onto that particular tissue. Okay, so that is kind of a negative point over there. Now over here, so I'm just writing over here that causing the discoloration of that part, causing discoloration of tissue, right? Causing discoloration of the tissue. Second point over here is that here, if the eschar formation is there, right, black eschar formation is there, it cannot penetrate that eschar formation. So can't penetrate eschar. Okay, that is also the negative point. Okay, but working good against the bacteria, working good against the bacteria, working good against the pseudomonas bacteria, and even the pseudomonas, and even the gram negative bacteria too. Gram negative bacteria too, right? Okay, second formulation we are having, that is the silver nitrate cream. You might have heard it very commonly also, silver nitrate cream. Okay, in the silver nitrate cream, what we are using actually, it is also having a good action against the basically pseudomonas, but here the gram negative bacteria, if you talk about, it is having a weaker activity against it, right? So over here, if you talk about, the silver sulfadiazine is used Hey guys, welcome back. Okay, fine. Okay, great. So I hope there is no issue with the audio and video again, guys. Okay, fine. Right. Okay, so I was talking about some drugs which we can use, topically, as far as the burns are concerned. So I had talked about the silver sulfadiazine 1% we can use, which is used very commonly. Then I told you that silver nitrate, but the weaker action against the pseudomonas and that is the basic thing. Weaker action against the gram-negative bacteria mainly, and that is the negative point against the silver nitrate. Then we are having one more good application, one more drug, that is the, so let me just complete it. Good action against pseudomonas. Good action against pseudomonas. Right. Okay. Now, third point over here, third drug which we shall talk about, that is the mefenide acetate. Mefenide acetate, right? Mefenide acetate 5%. Okay. It is having the capability to penetrate the S-char formation, right? Look at the power of this drug. Look at the power of this drug. It can actually penetrate. It is one of the carbonic anhydrase inhibitor, right? So main side effect is that it can cause the metabolic acidosis. In the burns patient, we know that metabolic acidosis might happen. That's why we were using which fluid? We were using the ringer lactate solution. Over here, the main side effect is the it can cause metabolic acidosis, because carbonic anhydrase inhibitors cause metabolic acidosis. So it might also cause that. So might cause metabolic acidosis. Because it is carbonic anhydrase inhibitor, but it can penetrate the S-char formation. That strong action it is having. So next thing is that after that we can use one more, that is the best agent, but not very commonly used, because it is not very commonly available also, that is the cerium nitrate. Now cerium nitrate, it is actually the best agent among all of these agents, and second thing is that it is having a good immunomodulatory actions, good immunomodulatory effects, right? It is causing the good wound care in the lesser time. Okay, fine. Now if we move further, okay, we shall talk about what are the causes of the death, what are the causes of the death following the burns, right? So the question are usually they are asking you the questions like, what is the cause of death, what is the late cause of death in the burns patient, what is the early cause of death in the burns patient, like that. So causes of death following burns patient, right? So causes of death following burns patient, following burns, right? So over here we shall talk about, for example, let's say the immediate cause, right? Immediate cause of death following the trauma, following the burns. Then the early cause, late cause. Early cause, I mean 1 to 3 days, and late cause, I mean more than 3 days. Okay, and that is the thing. Now if they are asking you the immediate cause of death, then probably in many cases it is the asphyxia. The patient is not able to breathe properly, and asphyxia might have been happened. That could be the immediate cause due to the airways burns, right? Early phase is that due to the loss of the fluid volume. So hypovolemic shock. Hypovolemic shock is the early cause of death in the burns patient. Hypovolemic shock, right? Next one is the septic shock in late phase. Okay, that has been asked n number of times. Okay, so that has been asked n number of times. The late cause of death in the burns patient, that is the sepsis, right? Okay, that is the septic shock. Okay. Next point over here is overall cause of death. If they're asking you overall cause of death, overall cause of death in the burns patient, then also your answer will remain same. That would be the septic shock. That would be the septic shock. Got it? So that is about this thing. And most common organism which is causing the infection in the burns patient, that is the pseudomonas, and that is giving the unpleasant sensation. And next thing is it is staining green color to the dressings, right? Okay. Now, if the patient is having some, in some special conditions, the patient might came up to your trauma unit or the casualty having the acid burn or the alkali burn. Okay. So main point which you need to remember in these kind of burns is we are never trying to neutralize these kind of burns. For example, if acidic burn is coming, we should not neutralize it with the alkali. Or if the alkali burn is coming, we should not neutralize it with the help of acid. We should not do that. So in case if the acid or alkali burns are coming in the burns unit, acid or alkali burns, let's say, okay, these are the chemical burns. So in these kind of cases, we should actually remember that these should not be neutralized. Simply, we should be washing these with water, right? Wash with water, okay, never neutralize, right? Never neutralize. And if there is some powder and all, okay, just brush it off and that's it, right? In the burns, if we are talking about next category, that is the electrical burns, right? That is the electrical burns. Now in the electrical burns, we are having two categories. Either there might be the alternating current burns, either there might be the DC burns, that is the direct current, alternating current or the direct current. Usually in our household supply, there is the alternating current, right? 220 volts. So with the alternating current, the patient is having the tetany. For example, if let's say you were having a shock, right? Not a shock, I mean the electric shock. Okay, if you are having the electric shock, okay, I'm sure you might have experienced it. I mean, most of you. So you are having that, that sensation. So that is the tetany sensation. So tetany means repetitive contractions of the muscles will be happening. Okay, if the AC current will be there, so AC burns will be actually causing the tetany in the patients. So tetany for that much amount of time when there was a contact with the electricity, so it is causing the tetany. Now tetany means the repetitive contractions of the muscle will be seen. Repetitive contraction of the muscles will be seen. Right, it will be causing the tetany actually, and due to that it will be causing the muscle injury. Okay, due to that, because repetitive contraction of the muscles are happening, so due to that muscle injury will be there, and due to that muscle injury, this is called as the rhabdomyolysis. Okay, this is called as the rhabdomyolysis, or I would say it will be causing the, the muscles are containing the myoglobin, and that myoglobin will be coming into the blood, and then through the blood it will be coming into the urine. So myoglobin can be present in the urine. So myoglobinuria, right? So due to that, you might be seeing the myoglobinuria. Okay. So the urine color might be changed, and urine might turn, right, tea color, or the reddish in color or the blackish in color. Okay, reddish or brownish color or discoloration can be there in the urine, right? In these kind of patients, right, you need to remember you have to give more and more IV fluids, right? Parkland formula was 2 into body weight into total body surface area burnt, right? But if the patient is coming up with the electrical burns injury, then you have to use this formula, 4 into total body surface area into percentage of total body surface area burnt. So if this kind of patient is coming, which formula you will be using for the fluid therapy? 4 into total body surface area which is burnt into body weight in kg. So please use this formula and look at the urine output also in these cases, right? If the urine discoloration you are seeing in the Foley's bag, let's say, right, then in those cases you have to give more and more amount of fluids and give the fluids until this color is not changes, until this discoloration is actually converting to the normal color or colorless, right? So till that point of time you should give the fluids to the patient. Okay, so that is the thing. So that's why monitor the urine output in these cases. Monitor the urine output in these cases. Okay, that is very important. Fine. Once we have understood this thing, then we shall move on to the next point after the electrical burns. Okay, so what I told you, in the AC burns, it can cause the tetany of the patients, right? Tetany, and tetany means the repetitive contractions of the muscles. Due to that, myoglobin might appear in the blood. Through the blood, it might appear in the urine. So myoglobinuria might be seen in the patients. And because myoglobin is going to the kidney, right? Myoglobin is going through the kidney and coming into the urine. Kidney injury might be seen as well. So acute kidney injury can be seen because the kidneys are in the stress. So acute kidney injury can also be seen. AKI can also be seen in this patient. Acute kidney injury can also be seen. As far as DC burns are concerned, okay, in the DC burns, we might talk about the heart block. We might talk about the heart block. So heart block might be seen in the DC burns patients. Okay, so once we are done with the electrical burns, now I'm moving on to the lightning burns, right? So third one, I'm just moving on to the lightning burns. So lightning burns, very easy to understand. Here also we are having two types. Either the direct burn might have been happened, or either the indirect burns might have been happened. Either the direct burns, either the indirect burns. Now in the direct burns, what can be seen? So if the burns are happening in the direct burns, actually in most of the cases, immediate death can be there, immediate expiry can be there of the patient, because if the lightning is falling onto some person, okay, so that will cause the arrhythmia in the person, and the patient might have been died at the spot. So in these cases, what is happening? The lightning is actually striking the patient directly, okay, and due to very high grade of electrical injury, the patient might be experiencing the arrhythmias and patient may die at the same time, right? So what is happening over here? Very high grade of electrical injury. Very high grade of electrical injury might be experienced by the patient. Due to that, the patient might feel the arrhythmias, and the patient might die, right? If you talk about the indirect one, the lightning, this time in the direct one, lightning is falling onto the person directly. In the indirect one, lightning is actually falling onto some object, into some metallic object, and due to that, that particular person is getting the shock from that or getting the burn from that, right? So the lightning, at this point of time, lightning is falling onto some metallic object, and through that metallic object, the person is getting the burn. That is considered under the category of indirect burns. So in the indirect burns, the person will be getting the burn through some metallic object, metallic object, right, which comes under the influence of lightning, under the influence of lightning. Fine. Okay, understood. So till now we have understood what is happening. Now direct injury, indirect injury with the lightning burns, right? In the indirect burns, we can see a very popular special kind of pattern, and MCQs are actually, they are asking the MCQs from this point, that is the which kind of pattern is seen in the indirect burns from the electricity burn, from the lightning burns, that is the filigree patterns. So in the indirect burns, we are seeing a very special kind of pattern, that is the filigree burn. Filigree burns, right? How they are seeing actually filigree burns. So let me show you as well. So this is the image of the filigree burns. Let me take it to that side, right? Okay, so these are the filigree burns. Okay, so here what you can see is that the patient is having the pattern, right? Lightning pattern. You can see the lightning pattern over here. So that is seen in the indirect burns, right? Obviously, the direct burn from the lightning injury you will not be seeing actually, because the patient will already be dead, right, due to the arrhythmia, sudden arrhythmia. But over here, the filigree burns can be seen in the indirect injury from the lightning. Okay, understood? That is important MCQ. They might give you this image and they might ask you what kind of pattern and in what kind of injuries you can see this. Okay, once you're clear with this, then we might come to the frostbite. Okay, we have talked about the burns. In the burns, once again, what we have talked about till now, we had a talk about the, you know, which patient should be transported to the specialized burn center. We had talked about that criteria, right? Then we had to talk about the overall management, like we have to evaluate the airways, breathing, circulation, and disability. Disability will be the same. You will be scoring, you will be calculating the GCS score and all, as I have told you in the trauma section yesterday. Then we will be talking about what kind of patient will be needing what kind of fluid. So I mean, what IV fluid should be using in these patients, that is the Ringer lactate solution. Now, if the patient is children, then we might use the dextrose containing solution. We might add up the dextrose containing solutions. I have told you that how to calculate which formula is there, how to calculate the IV fluid, that is the Parkland formula. I have told you that what kind of patients, after that, what is the Muir and Barclay formula, which is used for the colloid calculation part, right? Then we had a talk about the different kind of dressings, right? We had to talk about the zones of burns actually, which was zone of stasis, zone of coagulation, zone of hyperemia. Then we had to talk about the degrees of the burn, right? Stage 1, 2, 3, 4. And then we had to talk about the dressing materials. Then we had to talk about the special agents like silver sulfadiazine, silver nitrate, cerium nitrate, methylene acetate. Then we had to talk about electrical injuries and the lightning injuries, right? And the acid or alkali burns. And now we will be talking about the frostbite, and that's it about the burns actually. Now we are talking about the frostbite. So in the frostbite, if you will see, so let's start with the frostbite over here. Okay, so frostbite means basically the ice crystals are forming inside the tissue of the patient, right? So ice crystals are forming inside the tissue, right? So ice crystals are formed in tissue and they are causing the membrane injury in the patient, right? So ice crystals are forming in the tissue, right? Why the frostbite is happening? In a very cold climate, right? In those areas where the climate is very, very cold, right? Let's say minus 10 degree, minus 20 degree, minus 30 degree, okay, these kind of climate. So if the person tissues, body tissue will be exposed to that lethal environment for a very long period of time, then it might cause a frostbite of that particular part of the tissue, right? How the frostbite is actually looking like. So this is a picture of showing the frostbite. Okay, so here we can see how the frostbite looks. Okay, this is a picture. As you can see over here, blister formation can be seen, right? These are the actually vesicles. These are the vesicles actually which can be seen in the patient. Okay, these are the vesicles which can be seen in the patient. And then we shall talk about the grading of the frostbite as well, right? The grading of the frostbite as well. And here we shall discuss about the grading also. So this is the grading of frostbite. So here also we shall talk about the stage 1, 2, 3, 4, right? So over here, the first stage is called as the frost nip. Then we are having a second stage, third stage, and the fourth stage. In the first stage, only the partial skin freezing is there, as you can see in this image, right? In the second stage, full thickness skin freezing can be seen. So thickness will be increasing now. And over here, you can see the numbness might be there, and you can see the edema might be presenting for 4 to 6 hours, right? And the blisters can be seen within 6 to 24 hours. Basically, in the stage 1 of the frostbite, that is called as the frost nip, you will be seeing the hyperemia only, right? Second thing, in the second stage, you will be seeing the vesicles are developing also, right? Vesicles are developing, some of the skin loss can be there from there. In the third stage, you will be seeing that, the tissue loss actually started in the third stage, right? Tissue loss and the hemorrhagic vesicles can be there. zoom this image, you can see the vesicles, and inside that there might be the blood as well. Hemorrhagic vesicles might be there. So you can see the hemorrhagic blisters can be there. That is a keyword over here. Over here, the normal blister, normal vesicles can be there. Here, the hemorrhagic blisters can be there. In the fourth stage, you can see the black eschar formation. As you can see over here, these kind of patients might need the amputation as well, because gangrene might have been developed and we need to amputate that particular affected area of that particular frostbite. Okay, then we shall talk about the trench foot. What is trench foot? Usually if they are asking you trench foot, they are giving the image. Okay, this is more the image based question. They will be giving you the image, and that's how the trench foot looks. Not very good to see actually. Okay, might be disturbing for some. So this is the image of the trench foot. So here what you can see is, if the patient foot or if the patient body part will be actually coming in contact with the water for a very long period of time, right? In those cases, you might see that there could be the occlusion over there in the micro circulation. You can see that you can see the occlusion over there, and due to that, this kind of pattern can be seen, very not very good to see over here. So that is the trench foot. So what is happening over here? Prolonged exposure to the cold, and basically in the water, if the tissue is coming in contact with the water for a very long period of time, that too cold water, right? And the tissue is becoming damaged over there. Tissue is becoming wet, and this kind of appearance will be seen. So just documenting it, what I said, that prolonged exposure of tissue with the cold, prolonged exposure of tissue with cold water, okay, and due to that, what is happening? Tissue is becoming wet. Right? So that is the trench foot. At last, how will you manage these kind of patients? So management will be very simple. How to manage these patients? So management, in the management portion, what we will be doing is that, first of all, don't do the rewarming immediately. I mean, if the frostbite patient is coming, or if the trench foot patient is coming, it's not like you are pouring the warm water onto it, very warm water onto the particular affected tissue. Okay, because if you will be doing that, reperfusion injury might have been happened. So we need to avoid the reperfusion injury. So what we will do to avoid the reperfusion injury? We will actually gradually rewarming the particular tissue. So gradual rewarming is needed. Okay, so if you are pouring the water, it should be around 40 degree, right? Now if you talk about other kind of complication, what could have been happened? So hyperkalemia and the acidosis can be seen in such patients. So what you can see over here is that potassium levels might have been there, high level of potassium can be seen, and with that acidosis can be seen. So you need to do the correction for these kind of things. So hyperkalemia and the acidosis correction must have been done, right? Hyperkalemia correction can be done with the help of injection, calcium gluconate, or the potassium binders, right? Now with that, how to actually how to record the temperature in these kind of cases, because the patient temperature will be very on the lower side, so it will be colder actually. So better to take the temperature from the rectal area, okay, not through the axillary side or something else. Better to, because exact reading will be coming from the rectal route. So from the rectal route, we can take the temperature of the patient, followed by the esophageal route. So from where to take the temperature? It will be taken from the rectal route. This has also been asked. Rectal route is preferred, and then the esophageal route. Right? So this has been asked previously. Fine. So this was about the management of the frostbite and the trench foot, right? So we have talked about the burns actually, okay, and at last we can actually solve one MCQ over here, that for an example, okay, the patient had the burn, okay, involving the both upper limbs, right, both upper limbs and lower limbs. both upper limbs and lower limbs. Okay, the patient body weight is 100 kgs, let's say. Okay, so what amount of fluid should be given to these patients? What amount of fluid should be given to these patients? What amount of fluid should be given to these patients, right? Okay, so can somebody answer what amount of fluid can be given to these patients? Okay, first of all, obviously I'm just giving the hint. First of all, in this case, you need to calculate what is the total body surface area, okay, in percentage, right? Body weight is also given. I'm just waiting if somebody can answer that. If somebody can answer what should be the answer over here in this case. Okay, if somebody can answer this question, both upper limbs has been involved, has been burnt, giving you the hint that Wallace rule of 9 is used to calculate the total body surface area, right? So what should be the answer over here? So upper limbs and the lower limbs both has been involved. So over here, both upper limbs means 9 plus 9, that will be 18. Okay, and lower limbs 9 plus 9, that will be 18. So total body surface area came out to be 36%. So 36% total body surface area. Now you need to use the Parkland formula. You need to use the Parkland formula. Okay, meanwhile, question is open to all. You can answer in the comment in the chat box. So in the Parkland formula, I told you it was 2 into body weight in kgs into total body surface area that has been burnt, right? So just apply this formula. 2 into body weight is given, that is 100 kgs, right? And total body surface area, which is 36%. Okay, so 200 into 36, right? It became 7200 ml, right? Just a theoretical question. So 7200 ml, if this kind of question has been asked, so that is the answer. Okay, I hope everybody understood this one. Fine. So that was about the burn section. So till now we have talked about, yesterday we had to talk about the trauma, and today we had to talk about the burns. Please revise this topic, and we will be giving some MCQs in the Telegram group as well. Please join that group as well, and we'll be updating some of the MCQs over there as well. Thank you so much for joining this session, and I will see you in the next one. Thank you.